part 2 of finding somatoemotional links, somatic dysfunction, tissue texture abnormalities, and then addressing them with neuroocular release, the accommodation method. If you haven't already watched part 1, please stop, go find that one, watch it, and then come back here. So just a couple quick reminders from that one. The idea that a lot of your somatoemotional tissue texture changes are going to feel like a drawing together of the tissues. There's this guarding protective mechanism. And then as far as treating with the neuroocular release accommodation method, the idea that with accommodation, when someone is focusing their vision on something far versus near, you're going to have a response in the pupils that they will be either constricting as you go near, which that's going to be your parasympathetic nervous system, or as an object goes farther away, that the pupil is going to be dilating, and that's going to be your sympathetic nervous system. So you end up using where the person is focusing on to balance their sympathetic and parasympathetic nervous system and kind of dial it to the right spot that makes the area that you are addressing have a palpable change. Okay, so what I want to talk about in this one as far as the somatoemotional dysfunctions is that one way I sometimes come across these in a patient is while my hands are on them and I'm evaluating or treating, or lots of times I'm doing both of those at once, I might be asking the patient questions, talking about something, and sometimes I'll just feel their whole body tighten up, or I might feel a certain area get tighter. So sometimes I will actively engage them in conversation to investigate that a little bit more to try to see what's going on. And I can literally, have my hands on the patient and we were just talking about something, maybe an event that's coming up, and suddenly I feel an area tighten. So then I might ask them more questions about that event and find out that they tighten up when they talk about that there's people coming over. So then I might say, oh, who's coming to this? And then they list off various people and they say one particular person, their sister or something, and I feel them tighten up. And then I might ask them about their relationship with their sister. And then usually there's like a chuckle or a sigh or a deep breath or oh. And then then we can discuss that. And obviously not everyone is going to be comfortable using conversation in a therapeutic manner like a therapist or counselor. You're going to have to gauge your ability and comfort level with that. But you can still address what you felt come up using this neuroocular release accommodation method and use that kind of guided conversation as a diagnostic tool and not so much as a cognitive talk therapy tool. But it can be used to guide you in talk therapy as well. So we're going to set that aside though. That's probably better for an in-person workshop. And we're going to just talk about, all right, here I noticed something kind of tighten up when someone is consciously using their mind to think about a thing, and I can use that as far as diagnosis and treatment. So I can potentially also notice, all right, things feel not quite right, we'll say it's got a lot of emotional stuff, likes to hang out near the viscera. So maybe he's even come to me with complaints, has irritable bowel syndrome or things like that. So potentially I could monitor on his abdomen, and I could ask him to think about something in his life right now that is particularly stressful to him, if you could do that. I get a little bit of response. So I feel in his left lower quadrant, probably in the small intestines, a little bit of this kind of tightening. And then I say to the person, you don't have to think about that anymore. And have your eyes be open. They could have already been open, but his happened to be closed. And I'd like you to look at my hand. So I'm focusing on that somatoemotional stuff that just kind of got stirred up when he was thinking about the stressful event. Now I'm putting my hand in a position that balances. I have him close his eyes, and then he opens his eyes. And there's actually a little bit of an unwinding that started happening after he opened his eyes, as if whatever was kind of guarding and tethering the area now out of the way, and the body starts to try to fix itself. He wears glasses for distance, and so sometimes people will wonder if they have glasses on, do they have to keep them on in order to do the accommodation? No, you don't need to. It doesn't seem like it affects it. They can see enough of your hand to be able to try to focus on it, and it seems to get the job done. Another thing is that sometimes you'll find that where is the best place for them to be focusing on visually is actually somewhere where it's difficult for you to reach. Sometimes I'm like way up here like this. So what I normally do if it starts to get outside of my comfort area, or is actually like way out of even possibility for me to be able to, have my hands on them and feel what's going on and have them focus on it, is I will have them use imaginary hand. I find that this is better conceptually for them to be able to figure out if you've already at least done your hand once or twice, so they kind of know what you're talking about and how it kind of moves away from them and moves towards them. So when it's something like that, I'll be monitoring wherever the area is, and then let's see if we can actually find one on you. Not that one. Here's one. All right, his left wrist. There's something about that, a little bit of a guarding. And so I'll say, all right, you know how before I had my hand in front of your face and I was moving it up and down? So now I'd like you to imagine my hand, but I'd like you to imagine that it's like right about here, like 2 feet in front of the ceiling. Good. And then I'd like you to picture it very slowly moving towards you. And slow it down. Stop it. And move it a little bit closer, just a bit. Right about there. Okay. And then have you close your eyes. Poof, my hand disappears and you can open your eyes. So I say that so that, visually we're using this visualization and to really try to make the hand disappear so they're not trying to still focus on this imaginary hand when they open their eyes. I just say poof, it disappears, open your eyes. Sometimes I'll have patients ask me, when I open my eyes, am I still supposed to be trying to look at the hand, or when I close my eyes, am I supposed to still trying to be looking at the hand? And basically what I say to them is the important part is to be looking at the hand when it's actually moving in front of you, or the pretend hand while it's moving in front of you. And then when you've closed your eyes, you don't have to worry about thinking about what you're looking at anymore. You're good there. You can even use this on yourself, especially as you're getting comfortable with it and also wanting to feel what do the dysfunctions feel like from the inside, or what does it feel like when they release, or when do they release timing wise. And that imaginary hand really is helpful for you as a practitioner, getting used to how do I feel when it's in that right spot between looking a little too far or a little bit too close. The other thing that you might notice when you're doing it on yourself as well is, and also in patients, is every once in a while you come across something that actually requires them to be focusing on something that's a little bit behind their eyes or behind them. Obviously they can't really look back there, but whatever their brain is doing as far as trying to get the pupil to get in the place that mentally they're thinking about behind them, that can actually sometimes be that proper balance between sympathetics and parasympathetics to get that area to feel right. So basically, if you had your hand and you were coming down towards their face and you were feeling like, yeah, this thing is relaxing, it's relaxing, but it's not quite there, you could just then say, all right, imagine my hand is still here, take it away, and then ask them to imagine it gently just sinking down into their skull until you find the right area. So where is the right area? That's all about that area that you're palpating for and feeling. When does it feel like it's achieved that good area of relaxation? As far as getting them to think about a certain area, like when I was at his abdomen thinking about a stressful event, and then finding it, that accommodation area where it caused to feel the most relaxed, and using the neurological release. When you do work on emotional stuff, you want to make sure that you have time and that you're not going to open up some can of worms that then you're like really quickly, oh, I've got to go do something else, right? You know, no one would appreciate a therapist or anyone else kind of being like, hey, let's stir up all this stuff, and then, oh, I'm sorry, that sucks, you're like sobbing right now, I gotta go. Only once in a while do I actually get people crying on the table, and not usually uncontrollable, but same thing, if you are going to start treating these things, sometimes stuff like that is going to happen. And so just as we can use the accommodation to try to balance the autonomic nervous system for a particular emotional tissue texture issue, we can also use it to kind of bring them back mentally into a little better headspace. So I can, maybe if treating in his abdomen, I had started to get the sense overall he just doesn't feel right, or the way he's talking to me, or maybe he even says, you know, I don't know, I just feel like a little agitated or something. I could tune into that particular area, and I could ask him to think about something recently that made him happy or brought him some joy. And what I feel right here is actually kind of like a glow. It's like a filling of the tissues, so probably there's a relaxing of some kind of a tightness, and then as fluid comes in the area, kind of this buoyancy that comes out of my hand. And so I can have him open his eyes, since he likes to relax with them closed, which is fine. So think about that thing that recently brought you joy or happiness, and look at my hand again. And I don't want to make the buoyancy glow go away. I actually want to find the spot that makes it feel the most buoyant and full. That's right up here. And close your eyes. And open them. And if he had been the one who had said to me that he had felt a little anxious or something, you know, then maybe I'd have him take a few breaths in and out. And after he took a few breaths, I could check in with him again verbally and say, how are you feeling? Are you feeling any better? And then the next segment, I believe I'll do a bit more actually talking about how you can address somatoemotional flares, or even just tools you can give your patients as homework that they can do to keep addressing some of that emotional component to their somatic dysfunction.